Hello dear students. So today we are going to start with ophthalmology. Yeah, good afternoon all of you. Let's start with a quick revision of ophthalmology for your NEET PG. And how are you all? I hope you all have studied, because unless and until you study and ask questions, the fun is gone, right? The purpose of the session is gone. So hope you are studying very hard, right? And let it be a very interactive session. Now before I start with the session, let me first see you all. Yes, a good afternoon to all of you. Yes. So before we start the session, I would like to, before we start with this, I would like to suggest something, how to go about these 2 hours with me, right? So first of all of you pay attention. Yeah. So first of all, you have to have your copies and pens ready, right? We are going to try to revise all your important topics and questions in and around it, which you are going to benefit most if you are noting down well. Okay? And of course, anything that you would like to ask will be answered, right? Okay. So, is it fine? Can you all hear me nicely? Just 1 minute. Give me a second. Okay, na? Nice to meet you, Sri Aruna. Nice to know this. So, we will start with the session. You all can hear me nicely? No problem? I'll speak loudly. I think I've done this. See, if you're comfortable, we will start with the session. Yes, we can talk about that, Sri Aruna, one-to-one, and we will try to strategize something about it, where there has to be some reason behind all this, right? Yeah. Okay. Yeah, I think we can start now. You all are comfortable, correct? We will solve the question. First of all, let us solve this first question. So, I am going to go, I have just framed the questions chapter wise so that we focus on one chapter, revise it together, finish it off, go to the next, so that it's easier for you to learn, right? So, we come to question number 1. So, all of you, all of the following are located in the inner, so I will start with the retina because you all are very phobic about this chapter. So, all of the following are located in the inner nuclear layer of the retina except. Yeah, tell me, what should you answer? So, all of the following are located in the, it's a very simple question. The purpose was that you have to revise with me the layers of the retina and the cells that it contains. So, all of you, a very quick simple diagram with you all. Please make this diagram, let's make it together. So, we all know that this is the outermost layer of the retina is the retinal pigment epithelium, correct? And can we make it together please, quick? So, I am just making the different lines and naming it. This is the retinal pigment epithelium. Then we all know that there is a space, and that is called your subretinal space. So, this space is subretinal space, right? Then what is this line? This is your layer of rods and cones. Then comes your internal limiting membrane. Just make the lines. Then comes your outer nucleus, which is the nuclei of rods and cones. I am just revising. Quick revision please. Just purposes to revise. So I want all of you to keep on answering me also and revising it with me. So then outer nucleus, then comes your outer plexiform. Then what is there? Inner nucleus, and then comes your inner plexiform layer. What is the next layer? Ganglion cell layer, then nerve fiber layer, and then comes your internal limiting membrane. Internal limiting membrane. Correct? So these are the 10 layers of the retina. Now which layer and what is next after that? What is then in front of the retina? We all know is vitreous. So a condensed part of the vitreous, we will say this is your posterior hyaloid membrane. This becomes your anterior hyaloid membrane, right? Hyaloid membrane is nothing but condensed part of the vitreous, and this is the anterior segment of your eye. This is the lens. Simple? Okay. So once we are very clear with this, I think everybody is very quickly, I am tempted to revise this with you all, that what is retinal detachment? It is separation of retinal pigment epithelium from rest of the retina. We all know this. We are going to attempt the exam. Now outside this is choroid. We make a choroid here. Now tell me about the different cells in the different layers. So we all one by one, retinal pigment epithelium is clear to you all. Then comes your rods and cones, that is clear. Then outer nucleus is nothing but nuclei of rods and cones. Outer plexiform, again it will be what? The cells which are present in the inner nucleus, the dendrites of those cells, and the axons of the rods and cones. That is what is outer plexiform. Easy? What are the cells present in inner nuclear layer? So inner nuclear layer, we should know the cells that are present are bipolar cells. We all know about amacrine cells. We should know about horizontal cells. What are you asking, Sarika? So we are saying retinal pigment epithelium, internal limiting membrane, rods and cones, internal limiting membrane, outer nuclei, outer plexiform, inner nuclei, inner plexiform, ganglion cell layer, nerve fiber layer, and internal. Oh sorry, this should be external limiting membrane and lower is internal. Thank you for correcting. The outer one will be external limiting membrane and this one is your outer limiting membrane and this is the internal limiting. Okay, so amacrine cells, then this is your horizontal cells. These are the three main cells which are present in the inner nuclear layer. We have to know this, it is asked in the exam. Now second important thing is, what about the Muller cell? So Muller cell is actually spanning the whole of neurosensory retina. What is neurosensory retina? The layers leaving beside retinal pigment epithelium till the internal limiting membrane. So this is what is neurosensory retina, right? So spanning that, it is a supporting layer. This is what is your Muller's. We will just see the slide also. Today we are going to see lots and lots of slides. Okay, so these are the Muller cells. This was a quick revision. Let's go back to the question. All are falling are located in the inner nuclear layer of the retina except. So we know we all have already answered correctly. It is rod nuclei, correct? Okay. Once you know this, right? Another very important thing before I go to the next discussion or next show you the slide, very important thing is you should be very much clear about what is outer blood retinal barrier and what is inner blood retinal barrier. I hope you all are clear about that. Outer matlab, it is the strong adhesion of retinal pigment epithelium. When there is a strong adhesion of retinal pigment epithelium, no leakage is allowed from the choroid to come into the subretinal space, right? Because any collection in the subretinal space means there will be retinal detachment. So, but what happens? Of course, in few conditions like central serous retinopathy, there will be some disturbance, some mild collection and a shallow RD which is called central serous retinopathy. Correct? So, you should know this is outer barrier, strong adhesion of retinal pigment epithelium is, quickly keep writing, I am not writing everything. This is a revision session. So, a strong adhesion is your outer retinal, blood retinal barrier, and what about the inner? Inner is the capillary permeability. So, all the lining endothelial cells lining the capillaries, this is the inner barrier, and whenever there is any problem there, we say it is breaking of inner barrier. So, what is the catch point? I want you all to know this, note it down. Before we go to the slide, note it down that outer blood retinal barrier, if they ask you the question, they ask you like this, is broken where? It is broken in CSR. central serous retinopathy. And inner blood retinal barrier will be broken wherever there is edema, wherever permeability is increasing, it is breaking of inner barrier, right? So यहाँ पे हम क्या याद करेंगे? We can remember this as a CME, right? Yes, Kanishka, you will. This is all being available on the PrepLadder platform from April onwards. Yes, histology image is coming, happiness mode. I love your name. So first let's see this image. So this is only what we draw, it is reverse. In this case they have shown the choroid here, right? Then comes the same thing, pigment epithelium, rods and cones, outer limiting membrane, or you call it external limiting, it is the same thing. Then comes your outer nuclear layer, outer plexiform, then in inner nuclear, inner plexiform, ganglion cell layer, nerve fiber layer. Done? Now what is, see this, can you see this cell, right? This is what is your Muller cell. This is the supporting cell which is actually spanning from here to here, right? So remember this. Okay? One more question I remember here. So we will talk more about questions today. So there is another question about when they will discuss about electroretinogram. I think we will discuss it further in this session. So electroretinogram, you should know very quickly that it has A wave and a B wave, right? This is another question. So whatever I'll remember, I'll talk. So this is A wave, B wave and a very small C wave. This is your electroretinogram. You know this? What was asked to you? A wave corresponds to what? So A wave corresponds to what? You all should know. It is the activity of rods and cones. So A wave corresponds to the activity of photoreceptors. B for B, simple to remember. B for B, bipolar cells or Muller cells. Muller cells is a supporting cell, you can mention it. Mainly it is bipolar. What is C? We don't bother about C in an ERG, but yes, it is telling you the activity of, very small activity of retinal pigment epithelium. If I want to judge the retinal pigment epithelium, see in what is happening dystrophies, I hope you all remember, we will do electrooculogram, right? We will talk about it. Coming to the histology slide which you all were, so this is important again, this has been asked in the exam, right? So this is asked in the exam. Again, if we know the layers, it is not at all difficult, we have to just mark what are the nuclear layers. So again, let's study together here. This is the choroid. This one is your retinal pigment epithelium. Very nicely revise with me. This is your RPE. Uske baad yahi aayega, layers of rods and cones, right? Then there will be outer nuclear layer, then outer plexiform, inner nuclear, inner plexiform, then comes your ganglion cell and nerve fiber. We just have to know the layers, you can mark it very easily, right? ठीक है मनीष, हिस्टोपिक दिख गई? चलो नेक्स्ट पढ़े. आदित्य बोथ हिंदी इंग्लिश दोनों चलाते हैं, ठीक है, ठीक रहेगा, राइट? नॉट ओनली हिंदी, दैट इज़ नॉट पॉसिबल बिकॉज मेनी पीपल मे नॉट बी वेरी कंफर्टेबल विद दैट, लेकिन हाँ दोनों बीच बीच में हिंदी भी होगी, इसमें कोई चिंता की बात नहीं है, राइट? ओके, तो ये हो गया हम लोग के हिस्टोलॉजी. देन वी कम टू द नेक्स्ट slide. What is the next question? Let's try to understand the next. So before I go to the next question, I'm not satisfied. Let me discuss a few more things here that you should know about when we are talking about the anatomy and when we are talking about the layers of the retina. Do you all know that why are you getting a different type of hemorrhages in the retina? Sometimes it is a dot and blot hemorrhage, sometimes it is flame shaped hemorrhage. ये कैसे हो रहा है? अलग अलग शेप में कैसे hemorrhage आ रहे हैं आदित्य? बताओ. So why different shapes? हाँ बताओ क्या कैसे? तो so you know what, when you talk about the blood supply of the retina, I hope you all know that the outer four layer is supplied by outer four layers of the retina supplied by the short posterior ciliary, the same arteries which are supplying the choroid, that is the short posterior ciliary artery. And what about the inner six layers? Central retinal artery. अब वो central retinal artery की branch, now you try to understand when it is coming, it is at two levels in the retina. One is between OP and IN layer. So between the OP and IN layer, these blood vessels are perpendicular to the surface of retina, and along the nerve fiber layer, they are parallel to the surface of retina. यही कारण है, this is the reason any bleeding at this level is a dot and a blot, and any bleeding at this level is a flame shaped hemorrhage. Okay, so now we know why you are getting two types of hemorrhages. D for D, dot and blot are called deep hemorrhages, and this is called superficial. Don't you think it's reverse? This is the outer layer, This is the inner layer, this side, but we are calling this as deep and this as superficial because you are examining the patient from here, isn't it? We examine like this. So for us, the nerve, anything in the nerve fiber layer is superficial and that is deep. Got it? So these things are concepts which should be absolutely very, very clear to you. And what are the two types of exudates? Everybody knows, hard and soft, right? And they had asked you in your last exam, NEET PG only, they had asked you to mark hard exudates. So we are going to today look also about what are hard exudates. But what are hard exudates anyway? They are leak lipids. So just remember this, that there are two types of exudates, hard and soft, and hard exudates are leak lipids, right? I hope you all are writing down, not only chatting. And what are soft exudates? Soft exudates are axonal debris, dead axons. So do you realize axonal infarcts hai? Yani ki anywhere when there are too many soft exudates, it is a more serious thing. It's a more hypoxia indicating damage of the axons. Whereas hard exudates, these are just leak lipids. Okay? Okay. So I think these basics, and the question was on blood retinal barriers, and this is how they have asked you the question. And they have asked you also on very interesting, yes, they have also asked you about which layer the soft exudates are present. Can you all tell me this? Common sense. It's a axonal infarct. Where are the axons? Axons of the ganglion cells is what is forming the nerve fiber layer, na? So soft exudates, nerve fiber layer. And hard exudates, if they ask you, we will think like this. OP and IN ke beech mein we have those, generally the leakage is there. So we generally learn that hard exudates are mainly seen in outer plexiform layer and soft exudates are mainly seen in nerve fiber layer. Okay? Yeah. So we will learn this and keep this in mind. Okay? Right. Anything else I would like to add here to you all? Yeah, learn with me one more important fact here. That when we talk about the diabetic retinopathy, when you are talking about diabetic retinopathy, what is more common? More commonly are hard exudates, okay, and more commonly are dot and blot hemorrhage. And when we talk about, so this is a little factual which you have to understand, and sometimes they ask you this, so you should know, be very, very familiar with this. When we talk about hypertensive retinopathy, soft exudates are more common here, especially in malignant hypertension where there will be a lot of hypoxia and damage, right? Thank you, Harshit, thank you. Okay, and when we talk about your, thanks Pradeep. So talking about soft exudate, what did we just say? That it is more common in hypertensive, and secondly, flame shaped hemorrhage. Hypertensive mein flame shaped hemorrhage. Chalo, I think now we are in a position to shift to the next question and see what are the points we can learn in and around that question. So we come to this one. See, listen to me before you read the question. Whenever you are going to get all these types of detailed questions which will take so much time to read that you have already lost the game if you take too much time there. So what you will do, quickly first see last line, most likely the patient has, but more smarter step is to look at the options first, right? So when you look at the options here, okay, vitreous hemorrhage, okay, we are talking about something related to retinal detachment of vitreous finding. Then now we will read the question. A 58 years female patient is presenting with a progressive loss of peripheral vision. Progressive loss of peripheral vision. It goes in favor of retinal detachment. Keep in mind. With floaters. Now it is more towards that. We all know floaters are nothing but opacities in the vitreous cavity. In her right eye. Okay. Now there is no history of flashes of light. So no photopsia. What is flashes of light? I hope you know it is photopsia. Okay. Uske baad her ultrasound B scan shows the following findings. Look at the ultrasound B scan. It's a very, very indicative of the diagnosis. Let us see this. Are you all familiar with the B scan? So this side will be the lens and anterior segment. This is your posterior segment. This is the sclera, choroid and retina. Actually here the retina is all detached. Can you see this line? This is all detached retina. Now what do you see in the second scan? The position of the detached retina is now here. This is very interesting slide to show you the shifting fluid in the subretinal space. Where do you get the shifting fluid? All of you, we all know this. Can you all answer me? Where do you get, no Vikram, white tractional? Where do you get the shifting fluid? This is a detached retina, Vikram. So because it is not the traction that you are looking at. You are looking at a detached retina, and look, the position has changed. In one, this is the position of the detached. In the second, this is the position. This is because of the shifting fluid. Okay. So we are talking about now. You can tell me what is the answer. I'll wait. Yes, oxytocin. It is exudative. Kamini, very good. So it's an exudative. All of you, yes. Now you are answering correctly. It is exudative retinal detachment. समझ आ गया? Okay. अब हम वापस आते हैं. We will quickly revise. So what should you answer here is C. चलो. Exudative. What are the points we have to remember? In exudative, there is no photopsia, but you can get floaters. Right? Look at this one. This is a case of exudative RD. What are the points we remember for when you examine? Of course, first of all, whenever there is a retinal detachment, we just talked what is retinal detachment. It's a separation of RP from neurosensory retina along the subretinal space. Next question for you all. So we will now, the discussion has to be question oriented only, right? So next question for you all. Can you all answer me this? Which is the most common type of retinal detachment? Come on, answer me this. You all know there are three types: tractional, rhegmatogenous and exudative. Which is the most common? Rahul, you came late. Answer this. Good afternoon. Chalo, Rahul, tell me which is the most common type of retinal detachment? Very good, Sarika. So it is rhegmatogenous. Sarika, what is the meaning of rhegma? What is rhegma, all of you? Floaters can be suggestive of anything, Adnan. In rhegmatogenous, when there is a dispersion of the pigments, you get floaters. Do you remember that? Which is called Schaffer's sign, right? So sometimes when there is an inflammatory cause, you can see floaters in exudative RD as well. Okay. So here this is exudative. What are the points to remember? First of all, of course, we know that RD will present with a grey reflex because the retina looks red due to the rich vasculature of the choroid. When the retina is away from the choroid, it is going to look grey. So we will see grey reflex. And according to what part of the, Achha, answer this question first. All of you, listen to the question. Superior part of retina is detached. What will be the field effect? Very good, Neeraj. Yes, rhegma means break. Break can be both tear as well as hole. Neelam, so don't answer tear. Say it is a break, which can either be a tear due to traction or it could be due to degeneration. There can be a hole formation. Right? Okay. So can you all answer me this? Yes, very good. So you all are clear with this, that the field effects are always opposite. So if it is a superior retina detachment, it has to be an inferior field effect. Very good. So here we talk about what we are saying. This is, what are the points to remember? This is a convex configuration, which is typical of exudative. Number 2, very mobile, shifting fluid. Very important. Okay? It is very mobile and there is a shifting fluid. This is an important, this has been your exam question, so I have included this question here. What is the third point? No photopsia. Can you all now answer one question here? Photopsia occurs due to what? क्यों होता है photopsia? अक्षय, photopsia क्यों हो रहा है? क्या चीज़ है photopsia? Light क्यों दिखती है इस तरह से चमकती हुई? Why bright flash of light? वो क्या चीज़ है? बोलो. Dr. Kefin, watermarks will be seen in old RD. ठीक है? Because there are some changes in the retinal pigment epithelium. So that is a sign of we call it demarcation line, right? So that is an old. So यहाँ पे ये बताओ. Thanks Aditya. चलो बोलो फटाफट फटाफट. So no photopsia. Photopsia क्या होता है? ये तो बता दो. What is photopsia? Traction on rods and cones is causing flashes of light. Traction you will be seen in tractional. Traction can be seen when there is a tear, but it won't be seen in exudative. So we will learn this, that in exudative, no photopsia. Chalega? Okay, we come to what next we have to revise with us. This one is tractional. I think now everybody remembers this is a tractional retinal detachment and you can see the traction bands. What are the points we will remember in this one? It is concave in configuration. Okay? Concave configuration. What else would you like to know about tractional? You will get both photopsia, you can get floaters if there is any. If it is leading to tear formation, you may even get floater. Generally, we will learn photopsia. Floaters, sorry, correct this. Floaters ko nahi yaad karna. When it is going to lead to rhegmatogenous, tab floaters honge. Otherwise, we will just say there will be photopsia due to traction. Right? And it's a concave configuration and it is fixed, it is immobile. We will learn this RD is immobile. ठीक है? Okay, so whenever you are when we are talking about, okay, when we talk about this diabetic retinopathy, I'll just discuss a very simple pathogenesis for you all. You will find the retina very easy then. चलो अब आगे पढ़ते हैं. This was tractional. What else we have to see? Can you all tell me what I am trying to show with this slide? Typical history of a patient of rheumatogenic retinal detachment who is saying कि ऐसा लगता है आँख के ऊपर से पर्दा गिर गया. So curtain falling in front of the eye. See how her peripheral vision is धीरे धीरे due to the retinal detachment, right? So this is typically a history of rheumatogenic RD, ठीक है? And which is curtain falling in front of eye. अभी हम लोग ने क्या पढ़ा? We just learned that rhegma is a break and a break can be either a tear or a hole. Tear is horseshoe shape, it is due to the traction, and when you talk about hole you will say is due to degeneration. What is the most common degeneration where you can get a hole formation, all of you? Most common degeneration where you can get hole formation? You will answer? Tell me. Can you answer this? So Nikunj, when you are actually examining the patient on through your ophthalmoscopy, you generally see if the configuration of the retina is like this due to the fluid behind, or is it like this due to the traction and pull it becomes concave. So just learn this, it is concave. Okay, which is the most common degeneration? I will wait for this answer. I expect this answer. What is the degeneration which can lead to the hole formation? All of you. No, oxytocin. असली नाम लिखो यार. ये सब क्या है? Tell me. Tell me. Lattice. So myopic जब बोल रहे हो तो you have to be very specific. It is lattice. Very good, Nikita. We are talking about most common. You will like lattice degeneration. Nikita, one more from my side you should know. Another one is snail track degeneration. ठीक है? So these are the two degenerations which have got the highest risk of getting a retinal detachment. चलो, let's see what next we have. Okay, I think this is clear. Nikunj, ये इसमें तो कोई problem नहीं है because you can see the retinal tear here, which is typically horseshoe shape. We see this is the grey reflex and this is the red reflex, which is normal. So this part of the retina is all detached. Its inferior part is detached. The patient will have superior field effect. ठीक है? And this looks like this demarcation lines. It's quite demarcated. It's an old RD with a demarcation line. So it indicates old retinal detachment, right? Okay, so this was about this. Now then, yes, we will also mention that when you are talking about the treatment of RD, we all know we have to, in tractional RD, we will have to cut the traction bands and repose it. If we are talking, we have to see what is the cause. So here comes the common pathogenesis of any vascular disease where there is hypoxia, neovascularization, and that is leading to fibrosis and traction formation. Okay? Keep that in mind. So we have to first treat the root cause. We will do pan-retinal photocoagulation, PRP, and apart from that, we will cut the traction bands. Okay? Then when you talk about your exudative, everybody knows exudative is happening because of any problem in the choroid. Any pathology of the choroid. I may not write everything, but you should write everything. So when the pathology of the choroid can be either any tumor, neovascularization. So when you are asked about treatment of exudative, you will just say treat the cause. Then we talk about what about rheumatogenic. We all know we have to close the break. How to close the break? So one option is if the break is somewhere only on the upper 8 clock hours. Then what I can do, I can use some gases which will go up, create a tamponade, and you can just close the break and it will seal. This is what is called pneumatic retinopexy, right? So you should just know when you're putting the gas here, the gas bubble will create a tamponade and how this is sealed. You should be familiar with the term what is pneumatic retinopexy. Okay? What are the gases you can use? You should remember about SF6, sulfur hexafluoride, या फिर perfluorocarbons, PFCs. These are preferred. Right. Then we talk about Otherwise, what you do if the break is not there, we all know we have to seal the break again with the cryo, and we do a scleral buckling, right? Why do you do a buckling here, all of you? Because I am just giving you a simple concept clear kar lo. I am making very simple diagram for you. This is the retina, ye choroid hai, ye sclera hai, okay, and this is the anterior segment, right? So we are saying here, sorry. So what we are trying to say here, that if this is a break, do one thing. I cannot hold the retina and stitch it. What you do, you just take cryo from here and seal here. This cryo is minus 72 degrees centigrade with the freeze thaw method. Ye band ho jayega. But what happens once you seal? Why are you using, Subhajit? That's what I want to ask. I am explaining why we use the scleral band. So once you are sealing and you leave it, it can reopen. So aap kya karo? Whatever is the seal point, let it indent a little bit. So that indentation is mainly done by, so that if the seal point comes here, now your eye movement will not reopen it. This is solved by buckling. So you take two far points of the sclera, try to join it so the sclera buckles like this. When the sclera will buckle, the retina is going to internally indent. This is what is scleral band or scleral buckling. Okay, clear ho gaya? Okay, so once we do this, we come to the next slide. Yes, this is a, can you tell me what are you looking at, all of you? Let's enjoy the session also. If I just keep speaking, neither I am enjoying, neither you are enjoying. So now you will tell me what are you looking at. Chalo batao. Ye kya hai? Fatafat batao. Tell me, I am waiting. What are you looking at? Can you see something? Okay, I'll give you a hint. Kuch something like, no Jeetu, we are going in a very wrong direction. Okay, chalo theek hai, mid dilated pupil, I take it. What about this collection? Okay, I give you a guess. See this one. Ye kya cheez hai? What is this? It is like hypopyon, but it is not below. Normally, where do you see a hypopyon? It is pus cells in the anterior chamber is called hypopyon, which is seen like this. Is it clear? Here I am seeing some collection which is upwards. So I am saying now this time what I see here is, it is somewhere here. What is this? Can you now tell what is this? Yes, this is called, Saida, this is silicone oil which has leaked out after retinal detachment surgery. And this is what is called inverse hypopyon, not reverse, inverse hypopyon. Okay. So this is your inverse hypopyon. What is the other name? We also call it hyperleon. We also call this hyperleon. Okay? Okay. Chalo, we'll come to the next question. Very good, yes. What are you now looking at? What are you now looking at? This is the next slide, not the question yet. We will just look at this slide also. So this is your optical coherence tomography. You all know what it is, which shows the cross section of the retina, all the different layers. So what are we looking out here? Dekho, ye RP hai, right? And whole of the rest of the retina is separated like this. This is all retinal detachment, na? Separation of RP from, this is all neurosensory retina, isn't it? And what do you see? We see cystoid spaces here. Intraretinal edema. These are cystoid spaces. So you see retinal detachment with cystoid spaces, that means due to intraretinal. If it had been in the macular area, we call it cystoid macular edema. Ye kya tha na? Okay. So this was the OCT of retinal detachment that you will look at. So it's not a macular hole, right? Yeah, it's not. You will say CME when it is more at the macula. Yes, it is in the macula. Ye to fovea area hai. This is all still. This is a CME only, hai na? Apart from this, you will say this is a CME. So CME is not a wrong, but first you have to tell the RD na. Itna bada RD to dikh raha hai. So look here. Let me remove everything. See, this is separation of RP from neurosensory retina. Hai na? Right? Chalo. We come to the next slide. Now I want all of you to read the question. It's an interesting question. Chalo batao isme. You have to pick the odd one out. We will see all the slides and see. I will give you a help. Try to first see the angiographies. You will come to the diagnosis. Chalo batao kya hai? If I am seeing the angiography, okay, let me start with. Can anyone answer me which one is the odd one out here? A, B, C, D? Come on, quickly. We are taking too much time. We have lots and lots of discussion to do. So this one is A and this one is B, and you all are saying this is odd one. Acha. B is this one or B is this one? This is B, this is A, this is C, this is D. I think G2 is correct and Vikram has answered correctly. Arush has also answered correctly. Yes, very good. So it is C which is the odd one out. Let's discuss one by one. Very, very important slides. We'll start with D. What do you see in the D is a fluorescein angiography. Okay? You have injected the dye. I can see the dye in the blood vessel. Okay? But what do you see? That I cannot see any background fluorescence which should be seen. See, here you can see the background. Here it is all dark. This is what is dark choroid sign, or you call it silent choroid. This was one of your exam question. So we will put a Q here. Please always, whenever I tell you it's a question, you have to put a Q, because last day you will only look at those Qs. Okay? Make a big Q, not the small one. So we are saying that this is actually showing you a silent choroid or dark choroid sign. Kya cheez hai dark choroid sign? What is it? So dark choroid sign is nothing but, what we will remember here is deposition of lipofuscin in the retinal pigment epithelium. It is a feature of Stargardt's disease. Okay, so you are looking at the slides of Stargardt's disease, where there is deposition of lipofuscin. It is so heavily deposited in the retinal pigment epithelium that you can't see the choroid behind. That is why we call it as dark choroid sign. And is there no deposition here? Why I see this? It could be due to some atrophic changes in the retinal pigment epithelium. That is the reason. Okay? Ab aa jao next. Look at this slide. When you look at this slide, can you see any dye in the vessel? No. So this is not angiography. This is fluorescein autofluorescence. So it is FAF, fluorescein autofluorescence, and actually lipofuscin have the capacity to autofluorescence. इसी तरह से drusen's can autofluorescence. So this is what you see. These are just lipofuscin deposits which is seen in the autofluorescence. Again, it is typical of Stargardt's disease. Then we talk about this. Again, a mottled appearance, nail line appearance. This is again Stargardt's disease. Okay? And what do you see? See why we answered this. This is egg yolk appearance of Best's disease. Okay? So this is the egg yolk appearance, which is again nothing but lipofuscin appearance in the Best's disease. Certain, if we are not going to learn happily, we won't remember that. If we keep connecting our studies to hard work and sorrow and serious, then we will not enjoy studies. And to survive, we have to enjoy studies, isn't it? Chalo. अब इसके बाद हम पढ़ेंगे after this. Once you know this much, what is dark choroid sign and that this is, what was the other typical fundus picture of Stargardt's disease? Do you remember? Very important. See here. ऐसा लगता है ना मेटल को बीट किया है. This is beaten bronze appearance. This is a typical of Stargardt's. This appearance is beaten bronze appearance. Right. So if I ask you, let's revise Stargardt's. What are we going to talk? What are the points important? Let's note down. First of all, it is one of the most common macular dystrophy. Okay. When you say macular dystrophy, can we know which layer is involved? We are talking about retinal pigment epithelium layer cells are involved. Okay? And it is due to the mutation in ABCA4 gene. You may not learn it, it's okay, they haven't asked you this. What next point that you will know about Stargardt's? It is the dense lipofuscin deposit. Investigation we have just discussed everything, right? So that is done. And very important point here. So it is in initial stage only. This is mainly presented in the initial decades, and the patient will have vision of around less than equal to 6/60 in the initial stage itself. This is different from Best's disease. Best's disease, the vision drops in a late stage. Here it is happening in the early stage. ठीक है? And pay attention, note down. Pay attention and note down this. We will not give vitamin A. So no vitamin A is given in this condition. It is contraindicated. Why? Generally eye के लिए अच्छा ठीक है vitamin A खिला दो, हाँ, but not for Stargardt's. You know why? Because it enhances lipofuscinosis. So more lipofuscin deposition can happen. Okay, so it enhances the lipofuscinosis. So I hope this is one point you will keep noting down, right? ठीक है? So that was about this. Thank you, Mandar. So just inspire everyone. So yeah, so actually this is all tailor made, na? That's very helpful, and I keep getting lot of mails from all the post MBBS students also that my book is helpful for the university exams also, not only for the entrance exams. So I have been in so many years now, it's more than 21 years I am here. So a lot of mails I get and I feel very happy. I feel very accomplished. Thank you so much. You all are my encouragement and my inspiration to work harder. Stay blessed. And thank you for appreciating. We come to the next important thing that we will know is, this was Stargardt's, a quick revision. We will talk also about, when you are talking about dystrophy, we come to the next slide. This again a very important slide for you all. Make a cue there. This is what is egg yolk appearance, correct? So this is our egg yolk appearance, and we are talking about best vitelliform dystrophy or best disease. And then I always joke this, best means it's a name, okay? It's not best disease. It's a name. So it's a best vitelliform dystrophy. Again, childhood disease, right? It's again a childhood disease, but vision will go down in the later stage only, that the vision goes down to less than 6/60. What is egg yolk again? The lipofuscin. It is autosomal dominant and it's an RPE dystrophy again. Please remember this. So whenever there is an RPE dystrophy, which is the very important investigation we talk about, is electrooculogram. So electrooculogram is abnormal in Best disease. Questions of your exam. Number one question, EOG, how do you depict? What is Arden ratio? A quick revision here, all of you. First we will learn about EOG is electrooculogram. What is that? Tells the standing potential of your eye. This much is enough for the revision. So what we are seeing? What is the maximum potential in the light? What is the minimum in the dark? So light peak upon dark trough. This light peak upon dark trough means lowest in the dark and highest in the peak is called Arden ratio. So this was one question in your exam, what is Arden ratio? Next year they asked you, what is the normal value of Arden? It is 1.8, more than equal to 1.8. What happens in Best disease? In Best disease, Arden ratio goes less than 1.5. We will remember this. That's why I am telling you. We will not talk anything extra here. We will only talk for exams. ठीक है? So आपको ये याद करना है. We have to remember this, that for Best disease it is less than 1.5. Yes, very good. It is. We are talking about this, right? Then we next talk about what is this slide is. Again, after the egg yolk appearance, what is the next step in the Best disease? Some of it is reabsorbed. What do you look here? What are you looking here? This stage is called pseudo hypopion stage. Okay, so this is what is pseudo hypopion stage. Now when you say pseudo hypopion, I am prompted to ask you another question. Where do you learn about pseudo hypopion? Where else do you learn? So this is a revision session, so I can jump to any chapter. This is a hint. So pseudo hypopion और कहाँ पढ़ा है आपने? Where do you see pseudo hypopion? Come on, fast, quick. I'm waiting for the answer. Okay, so tell me this. I'm showing you the next slide. Till then, this becomes the vitelliform stage. Vitelliform stage पे आके, now what will happen? That the vision is going to go down and become less than 6/60. समझ आया? So this is the vitelliform stage. These are the stages, and what will be the last stage in Best disease? Atrophic stage. Last इसके बाद क्या आता है? We will say after this is atrophic stage. These are the different stages of your Best disease. Yeah, Yes, very good, oxytocin. We are talking about retinoblastoma, where again it can present as pseudo-hypopyon. These are not pus cells, but they are tumor cells. So any malignancy or tumor cells can present as pseudo-hypopyon. Oxytocin, can you answer one more thing here? First of all, please tell me your name, real name. If you don't want to tell like this, you can message me. So anyway, let me ask you this. Another question you answered so well. Where do you get recurrent hypopyon? All of you can answer me this. Question is for open for all. Where do we get recurrent hypopyon? Too many hypopyons we have learned. We have learned pseudo hypopyon, we have learned inverse hypopyon. अब एक ही बचा है, बताओ where is recurrent hypopyon? चलो फटाफट बताओ, फिर next पढ़ते हैं. Yeah, so I'll wait for the answer. Until then, meantime, we will go to the next question. So the next question says a 25 years old man. So see, quickly I can see that there are all angiographies. I have to pick up one. So I should know the diagnosis, correct? This is what it is saying. FFA findings will be, right? My last line. So now I start reading the question. So I read a 25 years old man presented with the complaints of distorted vision. So sabse pehle young male, right? He is a young male, he is presenting with distorted image, matlab, what do you call that? We call it metamorphopsia. Okay, metamorphopsia in his right eye. He has been on steroids, which is again contraindicated in which condition? What are we talking about? Can you give me the diagnosis first before answering? What will be the FFA findings? No, Neelam, the answer is not D. See it again, see it again. Why are you all answering D? I am not going to give you that simple a question. Don't expect. We will have some fun with some tricky ones, right? We are talking about preparation towards exams. We are not just passing time. So tell me this. Young male presenting with metamorphopsia aggravated by steroids, the diagnosis is? Bolo. Diagnosis, first answer me, what is the diagnosis? You are answering towards what? What is the diagnosis? No, it's not B, yes, it's B. So what is the diagnosis if you answer B? Write the condition, give me the answer. Yes, very good. So इन्होंने तो नाम ही अपना NEET PG रख लिया है, नाम रखने से ही हो जाता, फिर क्या बात थी? हाँ, very good. So it is CSR, we are talking about central serous retinopathy. So all of you focus here. Central serous retinopathy is breaking off. I just mentioned outer blood retinal barrier. Don't forget that. Okay? So we are talking about CSR. What is this FFA finding? Ink blot pattern. Ink blot pattern of. So what is the other pattern you know about CSR? This one. Smokestack. Two pattern milte hai na? But here what we see is an ink. That is your ink blot pattern of CSR. So this is the answer. Now what about the rest of it? We have to know that also as well, right? So tell me about A. What is A? A is an angiography where I see itna chota white dots. What is that? Hyperfluorescent dots are nothing but microaneurysms. So what I am talking about is background diabetic retinopathy. So these are microaneurysms. So this is a background diabetic retinopathy. Okay, we come to the C. C we have just learned is Stargardt's. We are looking at the autofluorescence. It is autofluorescence. Done? Okay, so this is Stargardt's disease. Now again a question for you all. Yeah, theek hai, very good. Acha, you all have not answered me about a recurrent hypopyon. If you won't, then we will miss that question. So keep answering that as well. What is D here? D batao kya hai? Kya dikh raha hai? D kya hai? What do you call D? What fluorescein angiography pattern is this? Quickly all of you. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, very good. So this is flower petal pattern. Okay, so very good. This is CME and this is your flower petal pattern. Ho gaya? Chalo. So now it's clear to you all. What are we talking about? Yeah, good. And what recurrent hypopyon, what is the answer? Which uveitis, Shri? Dr. Shri Rathod. Which uveitis recurrent hypopyon? ऐसे uveitis तो तुमने ऐसे बोल दिया कि मैं तो इंडिया में रहता हूँ, अब तुम ढूंढ लो कहाँ? हाँ? You have to tell me ना which uveitis. So tell me which uveitis. बताओ. सोचो. We are already there. We are the right chapter. Okay, I'll tell you this. This is Behçet's disease. Behçet's disease present with recurrent hypopion. Okay, all of you. We come back to this one. Look at this slide. What are you looking at? This is what is CSR, and the arrows are telling you ring reflex. पढ़ा था ना हमने, CSR is nothing but shallow retinal detachment. So ये जो shallow retinal detachment है, how will it look like? The light of my ophthalmoscope encircles the shallow RD. इसी को बुलाते हैं ring reflex. So we are talking about ring reflex here. ठीक है? Correct? अरे कोई बात नहीं डॉक्टर राठौर, इट्स अभी बहुत सारे मौके आएंगे, मैंने बहुत से सवाल पूछने हैं, आप बस ऑन द मार्क्स अलर्ट रहो बस. Okay, this is about CSR. Then we talk about the next question, next slide. Can you appreciate this? The red line is always the retinal pigment epithelium, and there is RD, but it is only at this foveal area. It is on the central area, not the rest of the area. We are talking about central serous choroidopathy or retinopathy, right? And do I see something here? I even see a RPE detachment. So in chronic cases of CSR, you may get this some changes in the RPE here. So what you get is RPE detachment. ठीक है? चलो next पढ़ते हैं. What do I have this for you all? देखो इसमें क्या है? All of you will answer this one. What is this slide all about? I can see a series of squares here, and some of the squares are distorted. First of all, what is this? It's an Amsler grid, all of you, right? You ask the patient to look at the central dot and then inquire, can you see all the squares nicely? Yes or no, and accordingly we will judge. If everything is regular and nicely seen, this is normal. But here you see, this is what is showing you distortion of the image or metamorphopsia. So what are the two conditions where you can get this? One we have just learned is CSR, ठीक है? तो एक तो हो गया CSR और दूसरा याद कर लो, remember the other one is ARMD, age related macular degeneration. So these are the two conditions where you can get metamorphopsia. Few points. When you are doing an Amsler grid, what is the, it's like a field test. You are asked to look at the central point and you are asked about the rest of the squares. So what are you actually, how much of the field you are testing? We will learn 20 degrees of central field, which is actually corresponding to the macular area. Okay? So yes, very many of you have answered nicely here. I am just seeing the chat. Wonderful. So we can come to the next. How many squares are there in the sheet, all of you? Number of squares in that Amsler sheet. And you generally give the sheet to the patient कि ये देखते रहो and try to monitor, because I hope you all know this was another question in your CSR, that majority of the times it is self-limiting. We do not need to treat it. We just have to follow it. Okay. So we give this sheet of paper to the patient. We try to explain him the nature of the disease if he is educated, and if you feel he doesn't want to listen to that, you have to give some multivitamins to buy time, and naturally it will go off. But yes, steroids are totally contraindicated. Please remember, steroids aggravate CSR, and even it can lead to chronic case. Once the CSR becomes chronic, now it is not self-limiting. Can you tell me, in a chronic CSR, what is the treatment? PDT, photodynamic therapy, in a milder range, not the same doses as in ARMD, but in a milder range we go for photodynamic therapy. ठीक है, याद रखना. Keep remembering this. Okay, what is this slide showing us? What is the, very good, it is 400, number of squares are 400. Very good, Trilok and Kavya and Anish, well answered. But I don't think that should be asked to you, but you should know it. What are you looking at now? OCT. OCT है, ये तो पता है. What do you see here is, this is what our cystoid space is. So OCT has some limited use, and where it can be, in seconds you can make the diagnosis. We are talking about CME. This is how a patient of cystoid macular edema will show the findings, right? Chalo, so this was all about CSR, CME, retinal detachment. Now we come to this question. Again the same tip. Why should I read the paragraph? First I will look at the options. Options are all different type of NPDR. Okay, this I'll keep in mind. Now I come to the question. Let me see the question. A 50 years old male, okay, patient presents with a gradual diminution of vision, which is more in the left eye than right. He has type 2 diabetes and hypertension. On fundus examination, what is, see, if they are asking you the different stages, this part is important. Dot and blot hemorrhages in all 4 quadrants of the retina. ठीक है, चलो ठीक है. Multiple soft exudates and hard exudates and venous looping was seen in 2 quadrants. The most probable diagnosis. So we will very quickly now revise the ETDRS classification of diabetic retinopathy. What is the ETDRS classification saying? Let's first revise this, then we will answer it. So ETDRS says, consider your answers again guys. That is why the latest classification in the latest edition of Kansky is different. And that is why again I will not give a simple question. So answer is not C. Chalo samajhte hain. ETDRS classification says you can divide diabetic retinopathy as non-proliferative DR and proliferative diabetic retinopathy. Pehle to ye hai. Now this non-proliferative is further divided as, so earlier it was mild, moderate, severe. Now in the latest it is very mild. It starts with very mild, then goes to mild, then to moderate, then to severe, then to very severe. Got it? Now what are these? You have to learn it. Very mild is only microaneurysms. Take. Now what about mild, moderate? Now before I go to mild, moderate and all that, I want you all, because it will become very easy for you if you understand the basics here. So I'll very quickly explain you the basics. Koi bhi vascular condition. So what is happening? There is leakage. Leakage is aggravating hypoxia. Hypoxia is causing again release. So is again causing more leakage. Actually it's a vicious circle. And this is going to lead to lots of edemas. So I am giving you a common pathogenesis of all the vascular pathology of the retina. So edema, exudate, hemorrhages, you are seeing everything because of increased capillary permeability and leakage. Okay? So once this is happening, it's a vicious circle, hypoxia, more leakage, more hypoxia, so this is happening. So edema, exudates and hemorrhages. अब क्या होता है? When this hypoxia keeps increasing, I want you all to note down this pathogenesis please. Keeps increasing, there is release of chemotactic factors. Okay? And this will lead to neovascularization. Now neovascularization in the retina can be NVD or NVE. D means at the disc, E matlab anywhere apart from the disc, elsewhere. Now what is this neovascularization doing? If you look at the first diagram that we made, your different layers of retina, the new blood vessels, if they leak a lot, they will fill the vitreous hemorrhage. Vitreous cavity. So one dreaded, so it can actually lead to 3 blinding complications, and these 3 blinding complications can be vitreous hemorrhage. Then what happens? You understand, no? Those layers that we draw, and this was the anterior segment. So if the new blood vessels, I am just making in short to explain you, is going into the vitreous cavity, it can cause bleeding and it can fill the vitreous cavity, and vitreous hemorrhage can be a cause of blindness. अब अगर इसमें there is associated fibrous tissue attached, it is going to pull, it is always there. Whenever there is a neovascularization, there is associated fibrous tissue. So when there is associated fibrous tissue, it pulls the retina, and that leads to another blinding complication, tractional retinal detachment. What next? Any hypoxia of the retina can cause hypoxia in the anterior segment, and this leads to neovascularization in iris. What is that called? Rubeosis iridis. These new vessels can then encroach the angle, leading to the third blinding complication, neovascular glaucoma. And इस पूरी कहानी को, the whole pathogenesis, we call retinitis proliferans. समझ आया? So this will fit in, right? So why you use laser? Can you tell me what is laser doing in this whole story? Interesting. Laser is actually it's nothing but it is burning the retina. That's why you can't do it repeatedly. It will damage the nerve fibers. But laser actually what it is doing, pan-retinal photocoagulation turns this hypoxia into anoxia. And when there is anoxia, there will be no release of chemotactic factors and no neovascularization. So all these dreaded blinding complications are prevented. This is what is happening, and of course you all know these days we have even smarter option of anti-VEGF drugs which we are giving intravitreally to stop this neovascularization and hence to stop the dreaded complications. ठीक है, कहानी समझ आ गई? So this is going to fit into DR, it will fit into little bit into HR, it will fit also in CRVO, in sickle cell anemia, all these the same story fits in. So it was very important for you all to be clear about this story. समझ आ गया? चलो, अब जब ये समझ आएगा chemotactic factors very nicely answered by Chandra is VEGF which is the most important. ठीक है? Of course, we have many others, you should know this, like platelet, if you want to write down platelet derived growth factor, basic FGF, insulin like growth factor, TGF, alpha and beta, and tumor necrosis. Actually, all are considered chemotactic. But of course, most important जो आपको याद करना है, vascular endothelial growth factor. हो गया? Yes, Divyanand has already said about PDGF. Chalo, so what I was trying to come to this one is, very mild is only microaneurysms. Another question for you all. Which layer are the microaneurysms present? We have already talked about the layers of retina. So which layer are the microaneurysms present? बताओ, चलो, बहुत देर से सुन रहे हो आप लोग. You have been listening for a long time, now answer me. Which layer are the microaneurysms present? And then the second one is mild. I will wait for the answer, I am going ahead now. So mild will means along with microaneurysm, along with this plus all types of hemorrhages, all type of edema. Edema all type मतलब क्या होता है? Edema at the macula, edema at the retina, edema around the disc. Okay. So everything is present, now it becomes mild. So along with hemorrhages, if this is, that is why when you saw that flow-C angiography where microaneurysms, there were some dark spots also which could be just blocked fluorescence due to hemorrhages. Then we called it mild, not very mild. Okay, तो ये हो गया आपका mild NPDR. अब बताओ what is moderate? Moderate is the same that you have learned as pre-proliferative stage. मतलब along with all the features of mild, what you will get is increased number of cotton wool spots. See, you are looking at a moderate NPDR with too many cotton wool spots because now the hypoxia is more. ठीक है? What else do you see? I can see looping and beading of veins. This is looping, this is beading. Look at this one. This is what is looping of the vein. Again we are talking about moderate NPDR. Okay? Then what else I can see? I can go for, these are large blot hemorrhages. What are large blot hemorrhages? They are nothing but venous infarcts. So this is an important topic, so I am taking into little detail, right? And lastly, IRMA, intraretinal microvascular abnormalities. What are these? These are shunt vessels. Okay? So all these things I would say in this case I can see lot of flame shaped hemorrhage, dot and blot hemorrhages. I can call this a large blot hemorrhage. These are the soft exudates, right? Or cotton, we call it cotton wool spots because they look like cotton wool. Okay? So you are looking at pre-proliferative, or this is a moderate NPDR, right? And this was again a moderate NPDR where you have just seen the looping. है ना? अब बताओ ये वाला क्या था? We haven't talked about this. These are the hard exudates. It has been your exam question, how to actually look at hard exudates. Look, why do you call it hard? Do you know this? Well defined margins. Why do we call that soft? Ill defined margins. Okay? So these are hard exudates, they are leak lipids. I told you this. And these are the hemorrhages, flame shaped hemorrhage. So this is, we are looking at mild NPDR, hard exudates, some hemorrhages. So this is a mild NPDR, this becomes moderate. What are the signs of moderate? Very quickly, increased number of cotton wool spots, looping and beading, IRMAs, right? Dr. Shri, we will talk about this. You can just message me on Insta or Messenger, Facebook Messenger. I am available there. I'll guide you, right? We are in the class now, so we'll talk that later. Okay, then we talk about is, after this, what is this stage? This is, if you look at this slide, I see again large blot hemorrhage. I see cotton wool spots, hard exudates, flame shaped hemorrhages. What about this? Look at this one. NVD. So we are looking at proliferative diabetic retinopathy. So where we are looking at is proliferative diabetic retinopathy. No, hard exudates, Divyanan, means they have well defined margins. Soft has ill defined, it looks like a cotton wool. ठीक है, don't learn reverse. उल्टा मत याद करो. Okay, then we talk about, coming back to your question. अभी तक question का तो answer ही नहीं है. So we come to this one. What is severe? Somebody has written and answered correctly. Severe is defined as 4:2:1 rule. What is 4:2:1 rule? I'll write here. 4:2:1 rule says is a definition for severe NPDR, which says hemorrhages and microaneurysms in all 4 quadrants. So if this is the optic disc, you divide the whole retina like this through the disc. So in all 4 quadrants, these are the 4 quadrants of the retina. And or second criteria, looping and beading in 2 quadrants. Take, or third criteria, IRMA in 1 quadrant. ठीक है? Got it? Now all of you pay attention. So go back to your question. This is or, but what was very severe now? Any of 2 criteria of 4:2:1 rule is very severe. If you see this question, it is not only in all 4 quadrants hemorrhages that are seen, but also venous looping in 2 quadrants. 2 criteria are fulfilled of 4:2:1. So our answer should be very severe NPDR. Okay? Now you will be careful. Yeah. No worries, Divyanan. No sorries, not needed. It's okay. Okay? Okay, we come to the next is your this question. Answer me this. Interesting question. Answer me this. The investigation of choice. What are you looking at? What are we looking at is this is your tumor in the retina, and most commonly we will be talking at our level is retinoblastoma. Now can you answer me what is this investigation of choice here? Investigation of choice. Come on, answer me, otherwise I will start feeling bored. Very good, wonderful. Everybody has answered correctly, I am happy. So MRI will always be, you don't want to expose the child to radiations, right? So you go for MRI to diagnose this, and it because MRI can also be seen intracranially and in the orbit, ocular, everything. There was another question of your NEET PG, and they had asked you, usually, commonly, what is the first investigation by which you diagnose a retinoblastoma? Then your answer should be ultrasound B scan. As a first investigation for diagnosis, generally it is commonly practice में इसी से हम पहली बार पकड़ते हैं retinoblastoma. So this was asked. Interesting? Yeah. So this and okay, answer me one more thing. X-ray, what type of view will you do for retinoblastoma, and what are you looking at? Sorry. So what is the view we want to do in X-ray, and what are we trying to look in a retinoblastoma patient? So we do Rees view, and Rees view is mainly showing you the optic foramen. ठीक है? Optic foramen हमने क्या पढ़ा था? What are the structures passing through optic foramen? So structures passing through optic foramen is optic nerve and ophthalmic artery, isn't it? So what do you see in a patient of retinoblastoma? See, let me first draw this diagram for you all, then I will discuss this slide. So for patients of retinoblastoma, what is happening? Do you know if this is suppose the eye, this is the disc and this is the nerve and this is the orbit. You should know this is an exam question. What is the most common mode of spread? Most common mode of spread is through the optic nerve. Okay? So if the most common mode of spread is through the optic nerve, what will happen when it comes to intracanalicular part of the nerve, when it is passing through the optic foramen? The malignant cells are going to eat the bone, and the finding will be enlargement of, draw the diagram please all of you, enlargement of optic foramen. Okay? समझ आया? सो एनलार्जमेंट ऑफ ऑप्टिक फोरामेन. यस सैमविकी डायरेक्ट स्प्रेड में थ्रू ऑप्टिक नर्व आंसर करना. ठीक है. सो दिस इज एनलार्जमेंट ऑफ द ऑप्टिक फोरामेन. दिस इज व्हाट यू आर सीइंग इन रीज व्यू. वी आर ट्राइंग टू सी दैट. इसका मतलब इफ आई गेट एन एनलार्जमेंट ऑफ इट मीन्स द ट्यूमर हैज स्प्रेड. इट इज सीरियस. ठीक है. Yes, you all have already, so I am rubbing this diagram now. So you all have already answered me this. What is this? We are looking at is white eye reflex. White is leuco, chorea matlab pupil. So we are looking at the white pupil or white eye reflex. Right. I have a question for you all. DD of leukochorea you all should know. I hope you know this. Most commonly we will answer is congenital cataract. Isn't it? What else you should know about this congenital cataract? What is the second? Second, of course, apart from retinoblastoma, what are the DDs? We are talking like this. So apart from retinoblastoma, whatever causes that you learn, that one is congenital cataract, then think yourself there can be a cyclitic membrane. You know? What else? There could be central fungal endophthalmitis. Then in children you can get toxocariasis. Right? Then we can get persistent hyperplastic primary vitreous. We can get Coats disease. Right? We can even get central retinal detachment, retinal dysplasias, and also colobomas, central colobomas. So there is a long list of what are the DDs of why you can get a white eye reflex. Chalo batao, all these diseases are collectively known as, if they ask you. Why are we talking about bullseye in between? अभी bullseye पे नहीं आया. So this is collectively known as pseudogliomas. ठीक है? These are all collectively known as pseudogliomas. So we will remember this. ठीक है? This is pseudogliomas. All the DDs. If they ask you most common cause overall, you will answer congenital cataract. It's a common mistake to answer congenital glaucoma. Please don't do that. It is congenital cataract, not glaucoma. है ना? चलो. What is this next slide related to retinoblastoma was also your exam question, and you are looking at, yes, flexed nerve intestina. This was the last year question for you all. So these are also called rosettes, right? See these rosettes, as you see, is there is a central lumen, and you can see here are the columnar cells. This is what is called flexed nerve intestina, right? And these are the microscopic differentiated cells. One is this. This is when the central lumen is absent. These are called pseudo-rosettes. So these pseudo-rosettes are also called Homer Wright. So we will learn it as Homer Wright. Wright brothers wala Wright hai ye, theek hai? Homer Wright. Okay. Then this one is your fluorates. We call these fluorates. So these are important. So I have just included the slides because it's important to know these. So these are fluorates. These are the three differentiated tumor cells that we will know. Chalo, what else we have? Ultrasound B scan, the first diagnosis. This is the USG B scan, appearance of a retinoblastoma. Right? Okay. Tell me this, the type of optic atrophy shown in the slide. Can you answer me? What slide are you looking at here? What is this slide? So what we see here is pale waxy disc. Can we see this? Pale waxy disc. It's a typical triad, attenuated arteries, right? And we also see as bony spicules. So what are you looking here at? We are talking about retinitis pigmentosa. This is a slide of RP. Since mid periphery is involved, it is a typical retinitis pigmentosa. कौन सी atrophy होगी? Any atrophy due to the retinal disease, what is that called? We will say it is called consecutive. So answer here is consecutive. For what are we answering infective endocarditis for? This is retinitis pigmentosa. Okay, yes, many of you have answered correctly. So you all remember your types of optic atrophy here. Let's start with a little bit of neuro-ophtha towards that. Types of optic atrophy, primary, okay, primary where the cause is not exactly in the eye, it is behind the lamina crebosa, है ना? Like multiple sclerosis हो गया, neurosyphilis हो गया, these are primary. Or it can be hereditary Leber's optic neuropathy is again causing primary optic atrophy. What is second and primary optic atrophy? Quick revision looks like, primary looks like. So, if you want to learn with me in my style, write down here primary, secondary, consecutive and glaucomatous. These are the 4 types of optic atrophy we will learn. Primary is clear disc margin and it is CW. So, this is my simple way. CW is chalky white in color. Then we come to the secondary. Secondary is a blurred margin and this is your dirty white in color. Consecutive batao, abhi bola, this is again clear disc margin and it is pale waxy disc. This is how we describe, pale waxy disc. And glaucomatous, I think everybody should know the changes in the glaucoma, that is cupping, that means cupping of the disc, nasal shifting of vessels, double bending of vessels, laminar dot sign. So, all those things are, we will talk about this today as well, is glaucomatous optic atrophy. Done? Chalo. So, yeah. Yes, rod spot is a feature of infective endocarditis. And what is rod spot? When you have talked about it, it is a soft exudate inside a flame shaped hemorrhage. Okay? So, a white center inside the hemorrhage is nothing but that soft exudate inside the flame shaped hemorrhage, which is called rod spot, right? You can see it in some leukemias also. Yeah. Okay. So, we now know what are different types of optic atrophy and how it will present. Okay? Chalky white, dirty white and blurred disc margins. Secondary will be due to any cause of papillitis or papilledema. You can learn it quickly like this. Then behind the lamina cribosa, all the causes are for primary, like as I told you, multiple sclerosis, neurosyphilis, even traumatic, nutritional toxic neuropathies. So, all these will come under primary. Consecutive में retinal disease. What can be the retinal disease? One is retinitis pigmentosa. It can even be central retinal artery occlusion. Okay? Yeah. So, these are the different optic atrophies. Look at this. So, this is what we just said. This is clear disc margin, chalky white in color. It is a primary optic atrophy. Clear hai? Yeah. This is your secondary optic atrophy. Dirty white in color. So, if you see, this is the part which is atrophic, but this is a normal color. Okay? Yeah. So, this one is your secondary and this is your glaucomatous. What are things you see in this case? Glaucomatous, can you see this? Cupping means you have to see from where that is bending out here. I would say it is around 0.7, 0.8 cupping, right? What is the normal cup disc ratio? If they ask you normal cup disc ratio, you should always answer 0.3 or less than equal to 0.3. But majority of the patients will be seeing this, showing the pathological changes when the cupping is around more than 0.6 or 0.7. So, ये दो अलग-अलग statements हैं, you have to appreciate the difference. So, if your question is normal CD ratio if they ask you, then you will say less than equal to 0.3. Okay? Yeah. But if they otherwise, generally glaucomatous patients, the CD ratio is seen as 0.6 or 0.7 is very alarming and you should really go for a workup. So, this is more of theoretical, this is more practically seen. But if the question is asked this way, you should answer this. Okay. So, this we talk about, we can also see the nasal shifting of vessels here. This is the bending of the vessels that is seen here. This is glaucomatous. Okay. Then we talk about the next question.